Good day everyone, I am Klein SIMBAJON and we are Group 5. Together with me are Gileana AGAPAY, King ALEGRID, Gail Jose, Isabel LALUCES, Marian MAÑIBO, Sofia Mendoza, Jiboy Oseo, Lance PINEDA, and Denise SANTOS, and Lance Chu. We will be discussing Case 2, Palo, and the continuous Supertyphoon threats. The first building block to be discussed is health service delivery. According to DOH, it is a provincial and citywide health system's unified system of governance, private sector engagement, and primary care strengthening. In our case, it discussed the lapses in providing proper health service which revolves during the time of Typhoon Yolanda. First, for the health service delivery situation, we have lack of support in dealing with mental health problems aftermath of Typhoon Haiyan, also known as Yolanda. According to the World Health Organization, at least 800,000 Super Typhoon Yolanda survivors may have experienced mental health problems in varying degrees. This includes hallucinations, anxieties, social withdrawal, and a lot more. It was also determined that 1 in 10 people have their state progressing to advanced depression. Unfortunately, there are only 70 trained health professionals and 300 community workers who are not enough to deal with this problem. Next, for the regional problem, is the overall health crisis after Typhoon Haiyan. More or less 4.2 million people experience serious food, water, and other important necessity shortage. Various outbreak of diseases and illnesses causes outbreaks in different regions. Injuries and such also led to the outbreak of tetanus, which is a very deadly infection. After typhoon, only a few hospitals were left standing and also medical supplies became short. This led to the inadequate support for those who are in need. In Palo, Leyte, there is also a problem in the hospital resiliency in the aftermath of Typhoon Haiyan. Due to a lack of component indications, private hospitals were more susceptible to the effects of storm surge. Compared to public hospitals, they had more serious damage. Private hospitals continue to release patients every day despite having collapsed owing to a lack of leadership. Compared to a public hospital, they find it really difficult to maintain. The key difference was whether or not the national government, its several agencies, and development partners offered consistent aid.
Moving on to health service delivery intervention. The first case is to promote the integration of mental health skills into the primary healthcare system through basic training and community integration based on what was implemented after Typhoon Yolanda. WHO states that it is currently coordinating with the DOH in order to train professionals regarding mental health treatment. This includes how to manage, diagnose, and increase the capacity of hospitals to better treat this issue. Mental health disorders are prevalent, therefore this case is important to tackle. Next is to improve pre-typhoon coordination in dealing with necessities and combating possible disease outbreaks. Increasing public knowledge regarding this issue is important, and coordination with hospitals and international organizations as well as medical teams is key. This includes strengthening its early warning alert and response network to watch for disease outbreaks and other public health threats related to food scarcity, water contamination, and other environmental hazards. Recommendations to foster hospital resilience is also important. As tragedy and crisis are hard to predict, we must always be ready at all times should they strike at any moment. This case tackles promoting hospital resiliency as crucial in the hospital setting. The case also focuses on the theoretical framework of a climate-resilient health system that we hope to apply in our country's hospitals.
For the first health service delivery assumption, since healthcare professionals have inadequate training and insufficient knowledge about mental health care, it was important for WHO to train volunteers about psychological first aid training or PFA. In line with this, there were proofs that depicted that this intervention does work. The following were observed. First, according to the research of Landoy et al. In 2015, in the context of the Philippine setting, it has been found that PFA was the most appropriate immediate intervention after a disaster. Second, a research from Boris et al. In 2016 also confirms that the mental health or psychosocial support program has indeed increased the availability, accessibility, and affordability of mental health services in Region 8. However, common problems that patients have seen in this intervention are unclear protocols for serious cases and for follow-up, scarcity of conducive venues, shortage of disaster response systems, and limited number of trained individuals who can deliver PFA.
Moving on, reinforcing strategic plans for the resiliency and sustainability of healthcare facilities should include disaster preparedness in the hospital's daily operations. The damage of Typhoon Yolanda overwhelmed local governments. It disrupted their capacity to deliver a humanitarian response in the aftermath of the disaster, needing fostered reforms to increase disaster planning and preparedness work in health facilities and across the health system. Most staff reported that they considered their hospital unprepared for Typhoon Yolanda and that the established protocols for disaster were ineffective. Considering the lack of baseline pre-disaster resilience indicators and the unpredictability of disaster should be addressed in a strategic plan on hospital resilience in disaster for future reference. With that, the World Health Organization's operational framework for building climate-resilient health systems adopted the approach of the Intergovernmental Panel on Climate Change by framing climate-resilient health systems as able to anticipate, respond, cope, recover, and adapt to shocks and stresses while improving the health of populations amid climate variability. Furthermore, continuous service delivery is facilitated by external support. With this, the flexibility and adaptability of disaster preparedness planning and training to multiple disaster scenarios should be the approach to fostering a climate-resilient health system.
In discussing the risks and suggestions for 3 interventions, we identified certain challenges. For the first intervention, additional resources are required, basic psychosocial training may not suffice for complex mental health needs, and healthcare providers may not have prior experience or training in mental health care. Mental health services may also not reach those who need them, and the shortage of mental health professionals may limit mental health services provision. Hence, there should be a comprehensive and sustainable mental health care system and programs, tailor psychosocial care training and education to the local context, and train more mental health professionals. Mental health services accessibility and availability should also be improved, and community-based mental health services should be strengthened. For the next intervention, the risks include unequal distribution, hoarding, inadequate resources, misinformation, and panic. Other risks are false alarms, logistic challenges, dependency on foreign aid, and neglect of long-term sustainable solutions. Thus, a more sustainable supply chain and storage system for food and water and public health education campaigns are vital. Likewise, boosting surveillance, local healthcare, and clear communication and collaboration strategy are essential solutions. The third intervention focuses on disaster preparedness in healthcare facilities. The risks include limited funding, personnel, infrastructure, and insufficient disaster preparation and training. Moreover, the policy implementation gap can widen and duplication of efforts, waste of resources, and ineffective disaster response and recovery may arise. Therefore, more funding for disaster preparedness, extensive disaster preparation planning and training, and resilience efforts monitoring and evaluation are necessary. Ultimately, stakeholder coordination and collaboration should be strengthened, and a resilient hospital atmosphere should be promoted.
The second health building block to be discussed for this particular case is health financing. According to the World Health Organization, health financing is a core function of health systems that can enable progress towards universal health by improving effective service coverage and financial protection. In this situation, financing proves to be a crucial factor in the management of typhoon disasters and calamities in general. Considering this, let us now dive in and examine the health financing situation in the Philippines, specifically in the Eastern Visayas, which often serves as the aftermath of strong typhoons. One notable health financing situation was the late release and inefficient allocation of recovery funds after Supertyphoon Yolanda hit the country in 2013. According to the National Economic and Development Authority, or NEDA, at least 729.27 million peso unused funds that were meant for the recovery of Eastern Visayas have been returned to the National Treasury. These funds were part of the budget for the Yolanda Recovery and Reconstruction Program created in 2016, where the allocations were even released at a later date, giving the agencies less time to procure and obligate the funds within the year. Furthermore, these funds were not even utilized, since some agencies encountered issues in the procurement of Yolanda projects, such as problems in the processing of documents and use of fraud agreement. However, with the unused funds, the Eastern Visayas Regional Development Council has requested to reallocate the budget to be used for the actual needs of the people in affected areas.
Another health financing situation was a late release of Emergency Shelter Assistance, or ESA, after Yolanda. The ESA involves government cash grants of 30,000 pesos for families whose houses were destroyed and 10,000 pesos each for those whose houses were damaged, with the goal of speeding up the recovery of the communities that were devastated by Yolanda. However, the distribution of the ESA only began in November of 2014, and even after 2 years since the super typhoon hit the country, many survivors are still waiting to receive their ESA. The late release of the ESA was caused by the late release of funds and counter-validation of beneficiaries to ensure that only the deserving would receive it. However, many families whose houses were damaged or destroyed were still categorized as ineligible for ESA. According to the DSWD, the guidelines for ineligibility were intended to ensure the prioritization of the most vulnerable. Analyzing both situations, we can say that sourcing funds after Yolanda was not the main problem. The government had the budget for programs that could help the people affected, but timeliness and inefficiency in allocating funds caused the different problems encountered in the recovery of the Eastern Visayas after the hit of the super typhoon. To combat difficulties encountered in the situations that were previously discussed, interventions were formulated by the LGUs.
One intervention is on the provincial aspect, which is to establish finance monitoring and tracking teams with engineers and accounting staff. In 2019, 85% of the funds for the Recovery Assistance for Yolanda program were already liquidated. Since the funds were transferred from the DILG to the implementing agencies such as the DPWH and the LGUs, the task of liquidating these funds lies on the shoulders of the implementing agencies. However, this process takes time, especially since many other projects are being implemented. Thus, this intervention aims to fast-track fund utilization by the LGUs. This ensures that disaster funds are properly allocated, liquidated, and utilized by the LGUs. Another intervention is on the local aspect. During the aftermath of Typhoon Yolanda, the immediate concern was to buy relief goods for the evacuees. However, quick response funds were not readily available and there were no operating banks in Palo. To address this, municipal officials were prompted to pay for initial expenses using their own money and just reimburse them. Additionally, the mayor issued promissory or IOU notes, which serves as a guarantee for the payment of the purchased goods. Since the documentation of these purchases are difficult during calamities, the Commission on Audit gives due consideration, wherein the regular rules for procurement and bidding are not strictly observed. Lastly, since Palo is often hit by typhoons, the Palo Municipal Disaster Coordinating Council already prepared for emergency disaster funds way before Yolanda. This was done through tax issuance, wherein an additional 2 pesos was paid for every payment made at the municipal hall. Moreover, the government also invested in disaster-proof structures such as the construction of seawalls, the declogging of drains, and the repair and clean of Palo creeks. This ensures that the municipality and its people can minimize the casualties of a typhoon.
Let us now move on to the health financing assumptions. For the first intervention, IOUs were used to acquire goods in response to the late release of funds. Unfortunately, no further information is available if this intervention worked or not. However, considering the situation, it was the fastest way to procure necessary goods as banks were closed and the QRFs were in the form of checks, so no cash was available. For the second intervention, RA 10121 delineated disaster risk reduction and management for the municipal level to MDRRMCs. So for Palo, their MDRRMC invested in disaster-proof structures such as construction of seawalls, declogging of drainage, and repair and clean of Palo creeks. According to the case study, the typhoon had caused damage to the municipality's water supply and sanitation systems. While the municipality was still heavily affected, we can see that the officials already knew what aspect they had to focus on. Fortunately, the unused Yolanda funds were also recommended to be used for individual water service connections in relocation sites, which can help improve access to safe drinking water and sanitation facilities. Furthermore, the municipality mentioned that they did not have enough money to purchase disaster preparedness equipment. If only proper allocation was given, more disaster-proof interventions can be prepared before the disaster, such as the building of evacuation centers. It is also noted that the aftermath of typhoon, the vice mayor mentioned to the communities that do not wait or depend for LGU assistance. This is a testament that health financing in the country was in a bad state.
For the last intervention, the DILG organized finance monitoring and tracking team together with engineers and accounting staffs to be sent to LGUs. This was done in coordination with respective COA offices to ensure that funds are properly liquidated, allocated, and utilized. In an interview, former DILG Secretary Anyos stated that the implementing agencies, particularly DPWH and LGUs, were assigned to liquidate funds for recovery assistance for Yolanda projects. However, as of 2018, some funds are yet to be liquidated since some RAY programs are still ongoing. According to UNTRR, accountability to stakeholders and funding agencies requires this monitoring and evaluation framework in disaster recovery to determine how well the programs work and which areas still needs improvement for future projects.
Moving on to the risks and suggestions for the first intervention. The use of promissory notes and temporary receipts may cause delay in reimbursement to the municipal officials who paid for the goods, which are also victims of the disaster. Moreover, corruption can also occur since audits can easily be manipulated without official receipts. Lastly, these IOUs can also get lost, which may cause problems in auditing as well. Our group suggests having contracts issued to the municipal officials that would assure payments and dates on when they will be given. Designating a committee that would track expenditures can also be done, while teams may also be deployed to oversee the overall fund utilization. On this next intervention, additional taxes can be a burden to already struggling citizens, while it is used for other purposes that do not involve disaster prevention. In addition, the construction of seawalls may cause recurring costs to maintain. It may also cause different effects on the environment in the area. Thus, close monitoring of the fund should be done. Citizens should also have a regular report on the projects being done using this additional tax. And lastly, exploring better alternatives to seawalls such as green infrastructure should be explored. For the last intervention, discrepancies in liquidation reports and problems may arise since responsibility of liquidating is passed around multiple agencies. Failure to liquidate assets may cause delay in delivery of health and rehabilitation projects. To correct this, designation of only one agency to oversee the liquidation of assets should be done and have them distributed to others when needed. Due deadlines on the submission of reports and appointment of people in charge of delivering the reports to important departments should also be considered. Lastly, the finance monitoring and tracking teams should directly supervise the project during the process rather than after to point out mistakes early on.